issues with compartment syndrome and leg ischemia with these. But you can't get as much flow out of these either. The vessels are smaller, so the cannulas tend to be a lot smaller than these. You tell which one's venous and which one's arterial? Yeah. So a big color difference between the two. This is the young lady that we took care of. I don't think we freezed her at all, but she's actually centrally cannulated, so her chest was open, the cannulas were put inside the chest, they were tunneled out through the chest wall, and then her chest was closed on top of them. She was a long term, she was on for 200 and some days. We were walking hallways with her. This was one of the first ECMO patients that we actually walked like long distances. You can see the cannulas, it's hard to see, but they're coming out on the bottom down here.
Was she waiting for transplant?
She was, yeah. She actually came in for respiratory failure of an unknown etiology. She was actually VV ECMO first, and because of her bad pulmonary disease, developed right-sided heart failure and left-sided heart failure. So she was then transitioned to opened her chest, transitioned to VA ECMO, and she was actually listed at one point for heart, lung, and kidney transplant. So she was on for a long time, but she walked out of the hospital with no transplants. It just took her a long time to recover. Yeah, she just finished her second year of college. She was 18, 17. I think she was 17. Yeah, no transplants. She was listed for 3 organs. It just took, we still don't know what her lung disease was at all. Nobody could figure it out. It was just, she just had this terrible ARDS, and they didn't know why. So it just took her lungs a long time to recover. Yeah, it was pretty crazy. She was very lucky. I think she just got off oxygen though, like last year. So she's still been on some supplemental oxygen, but can't beat that for. Alright, so this is on YouTube. I don't know if you guys have ever seen these, but just a couple, it's a quick 2-minute video. Just explains a little bit more about VA ECMO, and I don't know, I'm a picture person, so I like
VA ECMO is often performed using centrally placed cannulas, meaning that the cannulas are placed in the great vessels in close proximity to the heart. This animation shows highly oxygenated blood from the ECMO circuit being returned to the patient through an arterial cannula placed in the patient's ascending aorta. With extreme cardiac dysfunction on ECMO support, if the heart is not beating and the aortic valve is not opening, blood being pumped through this cannula provides 100% of the patient's blood flow. In this scenario, there's no mixing of the two circulations since no circulatory support is being provided by the native heart. However, as the heart recovers and begins to beat, the aortic valve opens and blood flow from the native circulation now mixes with blood exiting the centrally placed arterial cannula. The composition of the blood distal to that mixing cloud will depend on the relative outputs of each of the two circulatory systems. In this scenario, blood sampled from most regions of the body would generally have a similar composition. The exception may be the coronary arteries, which, due to their proximal takeoff from the ascending aorta, may be primarily perfused by blood exiting the left ventricle, and not by blood leaving the ECMO cannula. The perfusion of coronary arteries with adequately oxygenated blood can be problematic during VA ECMO support, even with centrally placed cannulas. Care should be taken to adequately oxygenate blood traversing the aortic valve if the lungs are capable.
Oops, no, I don't want to play that. Stop! There you go. That make sense? As you can see, as the heart starts to recover, you actually get some circulation going through the native heart, and then we start to wean down some more of our support and and then we can take them off eventually when they're ready. Alright, so if we switch to veno-venous support, this is a completely different type of support. So this removes from venous circulation and returns back to the venous circulation. So it's primarily used for respiratory support, does not provide any cardiac assistance. So this is the typical ECMO cannula that we use for our VV patients. So it's one single cannula, goes inserted percutaneously into the right IJ typically. It's super long, they're about this long. And it goes, so on this diagram here you can see this is the internal jugular, so it goes all the way down into the IVC, or SVC, sorry. So it's a dual lumen cannula. One side is your oxygenated blood and one side is the unoxygenated blood. So it pulls from the IVC and the SVC and then it returns towards the tricuspid valve. So we're pulling blood out that's unoxygenated, removing the carbon dioxide and adding oxygen, putting it back in to the right side of the heart, pointed towards the tricuspid valve so that the lungs essentially don't have to add much of anything to it. So it still goes through the native circulation, we're just pre-oxygenating the blood prior to getting it to the patient. So here's another video on that one, just because this is a little bit harder to imagine and figure out how it works.
The bicable DLC is designed to enable optimal extracorporeal support for patients with acute and chronic lung failure. Our use of a new hybrid polyurethane silicone material and stainless steel spring reinforcement provides strength, flexibility, and high flow rates. Its patented dual lumen design incorporates a collapsible membrane to support simultaneous removal and return of blood from a single insertion site. The bicable DLC is inserted through the right internal jugular vein. Upper and lower drainage ports are located in the superior and inferior vena cava, and blood returning from the external circuit exits the cannula in the right atrium. The bicable DLC simultaneously balances the removal of deoxygenated blue blood and the return of oxygenated red blood to minimize recirculation. This superbly engineered cannula is a major advancement in the practice of extracorporeal life support therapies.
That make sense? Mm-hmm. So you can see how, though, if the patient has very high pulmonary pressures because their lung disease is really bad, that their right heart will start to fail at some point, which is the typical problem that we have with these patients. So then they end up going to VA ECMO because we just can't support this provides no cardiac support. Their heart has to be functioning well. So here's an actual patient. These cannulas are huge. Yeah. Yeah. And thankfully, they're pretty easy. It's just a percutaneous insertion, so they're done at the bedside. They do have to have echo guidance to get the exit port pointing towards the right direction. Because if that port is not pointed in the right direction, you just have recirculation of the same blood. So, super important for positioning, but as far as getting them in, they're usually not too bad. So just kind of a comparison between the two. So with veno-venous ECMO and veno-arterial ECMO, we have a higher PaO2. So if you sample a radial arterial sample from the patient, with a VA patient, you're going to get a higher PO2 value, whereas the veno-venous, we're going to get a lower PO2. Why is that? Why do we have higher on VA and lower on VV?
Lungs are functioning.
Yeah, yep. Usually on our VA patients, even if their lungs aren't functioning, we're bypassing the total circulation. So we are providing more oxygen there. Whereas with VV, it has to mix mixed blood with the patient's native circulation, and their lungs are crappy. So on VA ECMO, a lot of times we have to have lower, we can have lower flows. Veno-venous, they need a pretty high blood flow rate. Veno-arterial bypasses the pulmonary circulation, whereas veno-venous maintains pulmonary blood flow. Veno-arterial decreases the pulmonary artery pressure. Veno-venous elevates your mixed venous PO2. VA provides cardiac support, VV does not. Veno-arterial does require an arterial cannulation, whereas VV is only a venous cannulation. So this is a few of the places that we have used. So we have a lot of options for where to put these, and it's based on the patient, what they need, and physician preference a little bit as well. Typically with our VV patients, we like to use that dual lumen cannula in the neck, just because it's one insertion site. It's fairly easy. If we can maintain them on that, we'll just stick to that. For a closed chest VA patient, so we usually will use the femoral arteries and veins. We've used axillaries in the past, but have had some issues with those as well. And then open chest, our typical choice is RA to aorta. So also is an international organization that focuses on ECMO. So every center that does ECMO around the world has the option to report to this organization. So we report our data to ELSO. It's basically a data collection method for all ECMO patients worldwide. So this includes Europe, and it's not all just the US. So this is a busy slide, but it breaks it down into neonatal, pediatric, and adult. So this is as of July of 2016. There was 78,000 ECMO patients total done throughout the world. And then this is their survival for ECLS or ECMO. So they survived to come off ECMO, and then this is survived to discharge or transfer. So if you look kind of down the row here, it breaks it down into respiratory failure, cardiac failure, or ECPR, which is ECMO initiated during CPR. So when you look at the discharge to transfer numbers, respiratory failure for kids is pretty good, 74%, 58%. ECPR and cardiac, typically around that 40 to 50% range. ECPR in adults, interesting, 29%, because out of hospital arrest survival is right around 8%, I think the last number I heard. So that's a pretty good percentage if you can get them on ECMO. And then cardiac around 40%. So our numbers, I wasn't able to get our numbers for this year.